Welcome to this Zoom meeting where we're going to introduce you to 4 experts who will show you that higher blood levels of vitamin D, which is a potent steroid pro-hormone, not just a nutrient, can help to reduce your risk of catching any coronavirus or reduce the severity of the illness. I had the pleasure in 2011 of hosting a conference where 3 of these people spoke. And the first one is Michael Holick, Bill Grant, and then David Grimes. So this is our agenda for today. Let's continue. Now, who is the target audience for this? We'd like to show this to the experts, and I'm based in the UK, in NICE and SACN and so on. These are the people advising the ministers. And we'd like to show it to the politicians, any doctors and nurses and other medical people, that's great. Health insurance companies would benefit from understanding this. And of course, it's for everyone. Now, they're going to be, in case of confusion, the Americans use nanograms per mil. And in the UK, we use the SI units of nanomoles. So in the UK, we have a definition of deficiency that is set by the Department of Health, probably to save money, which is 25 nanomoles or 10 nanograms. America has 20 nanograms. There's very good evidence that for good bone health, you need 30 nanograms. And there are some experts who issued a call to action who say that they think that the level ought to be, the optimum level is between 40 and 60. Without any further ado, let's go over to Michael Holick and hear from him.
Hello, I'm Michael Holick. I'm professor of medicine, physiology, and biophysics at Boston University Medical Center. And my goal is to give you a very broad overview about the important role of vitamin D for immune function. And this has particular importance in light of the COVID-19 pandemic that has now swept the world. And as you're well aware, there's been a lot of hype about vitamin D, and there's been a lot of skeptical conclusions about vitamin D. And I'd like to give you some perspective about it, and then also to discuss with you some recent studies that we have that hopefully will convince you that there is no downside to improving your vitamin D status, but there's a major upside if these observations turn out to be replicated. And so, is there any benefit that vitamin D can provide during this pandemic? And so, vitamin D, as you're well aware, is the sunshine vitamin, comes from exposure to sunlight. And once you make it in your skin or you ingest it in your diet, it then goes to your liver. That's converted to the major circulating form, 25-hydroxyvitamin D. And then it goes to your kidneys to get activated to 1,25-dihydroxyvitamin D. And we now recognize that basically every cell and tissue in your body has a vitamin D receptor. And so vitamin D plays a very important role for overall health and welfare. And so what are those functions? The earliest observation was made by Dr. Suda back in 1979. He realized that leukemic cells had a vitamin D receptor. And when he incubated them with active vitamin D, he showed that they became mature. And so the obvious question is, what is the function of vitamin D on your immune system? And we know from early work that I had participated in back in the 1980s that B and T lymphocytes have no vitamin D receptor, but only when they get activated do they develop a receptor. And once they have that receptor, they now interact with the active form of vitamin D and have a wide variety of effects on cytokine production. And as you're aware, the cytokine storm is a major cause for morbidity and mortality associated with COVID-19. And for B cells, which make antibodies, we also know that they get activated and they will recognize active vitamin D, and that active vitamin D does regulate antibody activity and immune function. We also know that the cells that gobble up your bacteria and viruses known as macrophages. When they get activated, they activate vitamin D. We've always known that vitamin D has been important in helping to fight infectious diseases like tuberculosis. Here in 1849, for example, cod liver oil containing vitamin D helped in reducing some of the consequences from tuberculosis. Vitamin D protects against TB. In 2006, a major discovery was made when we really understood how vitamin D is playing a role in these cells. It was Maudlin, Adams, and Liu who showed that if you take a macrophage and, for example, have it infected with tuberculosis, toll-like receptors are turned on. Why? It tells the cell to activate vitamin D. Why? Because active vitamin D tells the macrophage to make a protein called cathelicidin, which specifically kills infectious agents like TB and the coronavirus. And so it was well documented here in 1924 that exposure to sunlight was important for patients with TB. But we also know something else. It's always been interesting and curious that it's always in the wintertime that we're most affected by flu. And Hope Simpson in 1981 had suggested that there's a seasonal stimulus. What is that? Well, one possibility is that at the peak flu season, your blood levels of 25-hydroxy vitamin D, the measure of your vitamin D status, is at its lowest. There's a lot of association studies here from the third National Health Nutritional Survey. They showed that the higher your blood level of 25-hydroxy vitamin D, lower was your risk for upper respiratory tract infections. Here, a study done in Yale showed that the higher your blood level of 25-hydroxy vitamin D, on average 38 nanograms per ml, close to 100 nanomoles per liter, reduces by twofold upper respiratory tract infections. Study done in Japan, they gave school children during the winter 1,200 units of vitamin D a day and showed reduced risk of developing influenza A infection by 42%. So what is the evidence that vitamin D can improve immune health? So we did a study several years ago and asked the question, how does vitamin D affect your genes? And we took healthy subjects that were vitamin D deficient. We gave them 2,000 units of vitamin D a day for 12 weeks. And we looked with chip analysis at almost 23,000 genes in terms of their expression. Long story short, all of these blue lines are underexpressed genes, and all of those orange lines and red lines are overexpressed genes. And this is an individual before getting vitamin D, 291 genes. After getting vitamin D, we were able to markedly reduce the high expression and markedly increase those that were low expression. Well, you may ask the question, what is the impact? Does it have any benefit? And so we then looked at those genes and we showed that more than 80 different pathways are influenced simply by taking your vitamin D. DNA repair, apoptosis, which is cell death, killing cells that potentially become malignant, oxidative stress, metabolic processes, and most important, anti-inflammatory activity. We've known for more than 3 decades that your immune cells recognize active vitamin D, and this shows very nicely all of the interactions that occur by improving your vitamin D status on your immune function. Indeed, it's been demonstrated that a major effect is on cytokine production by immune cells, and it helps to modulate their production in a positive manner. And so is there any evidence that higher doses can improve health? Well, there are a lot of data that we've also published to show over a 6-month period of time that if you take 600 units a day versus 4,000 units a day versus 10,000 units a day, those on 600 units a day up and down regulated a few hundred genes. but those on 10,000 units a day were able to regulate more than 1,000 genes in a positive way. So what about vitamin D in the coronavirus, right? We know we have innate immunity and adaptive immunity, and vitamin D plays a critical role for both of these, right? And so for innate immunity, you're looking at activated macrophages and dendritic cells, and for adaptive immunity, it's the lymphocyte activity. And so 125 dihydroxy vitamin D, the active form of vitamin D, helps to regulate all of these processes. And so the cytokine storm is a major complication from having COVID-19 infection. And there is a lot of evidence that is now suggestive that if you're looking at what's called CRP, C-reactive protein, a major protein that's related to inflammatory activity, a very nice study early on had suggested that there may be a decrease in CRP and that this may help in reducing the cytokine storm. And so this is a major issue, and can vitamin D really do this? And so many different perspectives have been looking at the role of vitamin D in regulating immune function. And it does it in a variety of ways through the vitamin D receptor. And we also know that, like I said, macrophages, dendritic cells all respond to vitamin D. We also know, curiously, that this virus is very clever and is able to get into the cell through this called angiotensin receptor. And we now recognize that the active form of vitamin D regulates the production of angiotensin. And so it could be that active vitamin D will, in fact, help reduce risk of acquiring the infection if you can improve your vitamin D status. And so there's a lot of information to suggest this, but the question is it really true? And so we did a study. And we looked at 191,000 blood samples from throughout the United States for COVID-positive patients and asked the question, if they have a blood level that is higher, are they at reduced risk of acquiring this infection? And we just published in PLOS1 on September 18th that if you look at this slide, it's quite remarkable. If you look at 20 versus 55 or 60, you can see that there's about a 54% decline in risk of acquiring this COVID-19 infection. So simply by being vitamin D sufficient reduces risk by 54%. Whether we looked at northern or southern latitudes in the United States, the effect was still the same. Also, African Americans and Hispanics are particularly high risk for many of the complications from COVID-19 infection. And we've shown now that African Americans and Hispanics, because of their dark skin coloration, reduces their ability to make vitamin D in their skin, higher risk of vitamin D deficiency, and higher risk for acquiring this infection. We also looked at age. And even though we're worried about elderly and being more prone to the complications, we showed no difference. We also looked at males and females, no difference. So across the board, the higher your blood level of 25-hydroxy vitamin D, lower is your risk for acquiring this infection. We also now just released on September 25th our latest study. 235 patients admitted to the hospital with COVID-19 infection. 70%, actually 74%, had severe disease. And we asked the question, what is their blood level of vitamin D? And does it have any impact on the consequence? And so, and as you can see, we're starting to now get a fair amount of publicity about this. Implying that improving your vitamin D status could have a significant impact, here reducing risk of infection by 54%. So in this PLOS1 article, we showed a couple of, made some observations. The first is we looked at severity, we looked at unconsciousness, we looked at hypoxia, and ability to obtain oxygen and have consequences. And we showed that, in fact, if you're vitamin D sufficient, much less likely to have these complications. We also looked at C-reactive protein, right? It had been speculated that C-reactive protein is lower at lower latitudes. We now have evidence that CRP is lower in patients with the infection and having higher blood levels of 25-hydroxy vitamin D above 30 nanograms per ml, 75 nanomoles per liter. We also looked at lymphocyte count, because if you have higher lymphocyte count, that also helps you in fighting this infection. And we showed, again, those that were vitamin D sufficient had higher lymphocyte count. So we have good evidence for patients in the hospital with severe infection. If they're vitamin D sufficient, they're less likely to be unconscious and less likely to have many of the immunologic cytokine storm type of activity associated with it. We also asked another question. What about relationship of their vitamin D status and risk of dying? What we found remarkably, and it's consistent with lots of observations, right, is that mainly older adults are at higher risk for death. And that's what we observed as well in this hospital population. We showed under the age of 40, we didn't see any deaths. But over the age of 40, the higher your vitamin D status, lower was your risk of dying from this infection. So should we be testing everybody? I'm not going to bore you with the details, but as hopefully I'll convince you in a moment, vitamin D is one of the most non-toxic fat-soluble vitamins, contrary to popular belief. And here's a very nice study showing just loading doses of really huge amounts of vitamin D had no negative consequence. So how do you treat it, right? Well, when your gas tank is on empty, do you get a liter or a gallon of gas? No. So we started back in 1998 and showed that if you give 50,000 units once a week for 8 weeks, equivalent to about 6,500 units a day, we're able to correct vitamin D deficiency with no problem. And then what do? So we keep our patients on 50,000 units every 2 weeks. It's equivalent of 3,000 units a day, and they remain sufficient. The question is, if you're going to be on this level for such a long period of time, is it going to cause toxicity? Because maybe a couple of months or even a year, you don't really know. So we did the study, and we did a 6-year study following these patients, on average taking 3,000 unit equivalent a day. No one was toxic. They were in the preferred range of 25-hydroxy vitamin D of about 40 to 60 nanograms per ml, which is about 100 to 150 nanomoles per liter. And so do you need to do screening? And the answer is no, because we showed very nicely. I took all my patients and put them on this dose without testing their blood level. And we showed that there was no toxicity in a clinical setting. And so whether you start out at vitamin D deficiency level or even sufficiency, on these doses will not cause toxicity. And what about vitamin D2 versus vitamin D3, right? We showed many years ago, it doesn't make any difference. More importantly, what we also showed was in healthy adults, if you take 1,000 units a day, you will not become sufficient. Will you become toxic? Long story short is, we and others have shown, you can take up to 10,000 units a day and not worry about toxicity. Here, a very nice study done in Canada showed that adults taking up to 20,000 units a day, they were not toxic in any way. What about children, right? Study was done by Catherine Gordon and showed you could give children 50,000 units once a week for 6 weeks to correct their D deficiency, and 2,000 units a day. Pregnant women, the same thing, up to 4,000 units a day. Hollis and Wagner showed no toxicity in serum calcium or urinary calcium. But you can become toxic. We wound up with a patient that had bought a product on the internet. He thought he was taking 1,000 units a day. The company forgot to dilute it. He was taking 1,000,000 units a day. This will cause toxicity. And so we treated him, and as a result, quickly recovered his calcium and blood level of 20-hydroxy-D gradually came down, he had no complications from this experience. It's difficult to become vitamin D toxic. Feed your genes right with vitamin D, right? We need vitamin D from birth until death, right? With this COVID outbreak worldwide, we know vitamin D deficiency is common. So how much do you need? We know from a very nice study in Maasai herders and Hasta in Kenya, their blood levels on average are 40 to 50 nanograms per ml. How do you get there? You would have to be on 4,000 to 5,000 units a day. And so the other obvious question is, what about the goal? The goal should be minimum 75 nanomoles per liter, 30 nanograms per ml. Prefer range based on our published studies, 40 to 60 nanograms per ml, 100 to 150 nanomoles per liter. This is likely where your blood levels lie, right? We showed 1,000 units a day for an adult will not make you sufficient, right? Adults at a minimum 2,000 units a day. Children should be on 1,000 units a day. Best source, of course, is sunlight. But how much time of day, season of the year? In the UK, you can't make any vitamin D from about October until next April, right? And so we developed an app that's free, dminder.info, and it'll tell you when you can make vitamin D, how much you can make, and it warns you to get out of the sun so you don't get a sunburn. What do? Sun protection on my face, but not on my arms and legs. And I take 6,000 units of vitamin D a day. My blood level, 72 nanograms per ml, right? Vitamin D deficiency is probably the most common medical condition. And we just published in Nutrients a review article on this. And if you look at this, right, for immune function, vitamin D plays a critical role, including reducing risk of acquiring COVID-19. There is no downside to increasing your vitamin D intake, right? You don't need to be a genius to know this. We need sensible sun and vitamin D supplementation to maintain a good vitamin D status in order to fight this viral infection, right? This is not a hypothesis, right? Vitamin D is important for your health. And I thank you very much for your kind attention.
I'm William Grant, Director of Sunlight Nutrition Health Research Center in San Francisco, California. I've been studying vitamin D for about 20 years. Today I'm going to talk about three things. One is the mechanisms related to COVID-19 from vitamin D. Second, go over a number of observational studies of 25-hydroxyvitamin D and COVID-19 incidence and severity and death, and then a couple of studies on treatment of COVID-19 with vitamin D. The mechanisms of how vitamin D helps fight COVID-19 are outlined in this schematic. So the circulating form of vitamin D goes to the lung and other organs, including the kidneys, where it's converted to 125 dihydroxyvitamin D, which is a hormonal version of vitamin D, which when it gets to vitamin D receptors, affects gene expression in the chromosomes. So it has a number of actions that are related to COVID-19. It upregulates antimicrobial peptides. It downregulates some of the T helper cell functions. It downregulates the inflammatory cytokines, modulates MMP9, increases the anti-inflammatory cytokines such as IL-10. And that has many important effects on the respiratory system, such as acute respiratory tract infection reduction, inflammatory reduction, asthma reduction, and increase in lung function. Human cathelicidin is a polypeptide with antimicrobial and anti-endotoxin properties. It reduces survival of viruses by puncturing the surface, whether or not they have an envelope. When the innate immune system produces too many pro-inflammatory cytokines, the resulting cytokine storm can damage the epithelial layer of the lungs, vascular system, and other organs, as well as increase the risk of pneumonia. Vitamin D reduces the risk of the cytokine storm as we've outlined in a paper in Nutrients this year. Systemic inflammation is an important underlying factor, risk factor for COVID-19. Systemic inflammation increases with age, and the elderly have more systemic inflammation due to inflamed aging, and therefore greater risk of COVID-19. The young have very little system inflammation, thus the young are much less likely to develop severe COVID-19. And this is shown in a schematic from India, showing that it's the younger people who are more likely to be diagnosed with COVID-19, but it's the elderly who are more likely to die from COVID-19. Furthermore, regarding the inflammatory markers, this shows the relationship horizontally is a logarithm of 25-hydroxyvitamin D from, I think, 10 to 50 nanograms per milliliter. On the vertical, we have the logarithm of C-reactive protein, the normal overview of inflammatory biomarker in the body. So you see that the purplish squares are for people with inflammatory disease. They have much higher inflammatory biomarker than the people with non-inflammatory diseases, shown by the blue crosses. Okay, now I'm going to go into the a quick overview of the observational studies. There have been about a dozen or so observational studies primarily based on either stored 25-hydroxyvitamin D in a prospective study, or 25-hydroxyvitamin D measured at the time of diagnosis. These are generally small studies. The one from Israel actually had 782 people, but the others are anywhere from 27 up to a couple of hundred. And what they're showing in general is that there's an inverse relationship between 25-hydroxyvitamin D and severity of or death from COVID-19. For example, from Israel, there's a odds ratio of 1.95 of having COVID-19 for low versus high 25-hydroxyvitamin D, although they found age to be more important in their analysis. Mexico found that those with less than 8 nanograms per milliliter had a 3.7 times greater risk of death than those with the higher values. So now let's go down to some of these in more detail. The study in Switzerland looked at 27 people who tested positive with a PCR test for COVID-19, and they had a mean 25-hydroxyvitamin D concentration of 10 nanograms per milliliter. Patients who came to the hospital thinking they had COVID-19 but tested negative had a mean value around 25 nanograms, which is just about the same as other patients in the hospital who did not have COVID-19. So another example that there's a significant difference between vitamin D status and COVID-19. Here's a study from Italy. They looked at survival versus 25-hydroxyvitamin D in patients with acute respiratory failure. The mean 25-hydroxyvitamin D was 20 plus minus 12 nanograms per milliliter. So after 10 days of hospitalizations, patients with less than 10 nanograms per milliliter had a 50% mortality probability, while those with 25-hydroxyvitamin D greater than 10 nanograms per milliliter had only a 5% mortality risk. And here's the Kaplan-Meier curve showing out to about 25 days that a few died who had greater than 10 nanograms per milliliter, but almost about half of them died if they had less than 10 nanograms per milliliter. A study from Austria looked at 109 COVID-19 patients and categorized them by mild, moderate, and severe illness. Those with mild had around 25-hydroxyvitamin D around 65 nanomoles per liter, moderate had around 55, and severe had around 52. So there wasn't much variation in the 25-hydroxyvitamin D, but there was a trend. And also the parathyroid hormone, which is controlled in part by vitamin D, increased as the severity increased. Now, you're probably all familiar with the UK Biobank studies looking at 25-hydroxy vitamin D data in COVID-19. So UK Biobank recruited over 500,000 participants aged 37 to 73 years between 2006 and 2010. So baseline exposure data, including serum 25-hydroxy vitamin D concentration, were then linked to COVID-19 mortality. But they were using the 25-hydroxy vitamin D for that period 2006 to 2010. What they found was that if they did a univariable and multivariable regression analyses, they got different results. And they had 656 patients with confirmed COVID-19 infection, of whom 203 died of COVID-19 infection. So their over a decade-old 25-hydroxy vitamin D concentration was associated with severe COVID-19 infection mortality univariably, about a 8% reduction for every 10 nanomoles per liter increase in 25-hydroxy vitamin D. But after they adjusted for the confounding factors, including age and sex and ethnic background, etc., that dropped to 2%. That was not significant. It was also not vitamin D Deficiency was also not independently associated with either COVID-19 infection or limited mortality. But there are two problems with the UK Biobank data for this work. First of all, the 25-hydroxy vitamin D concentrations were obtained too long ago. As I've shown in several publications, if you look at the follow-up period after drawing the blood for 25-hydroxy vitamin D and look either for all-cause mortality rate or for cancer incidence, as you get to longer times, you lose the association. That's because 25-hydroxy vitamin D changes with time, changes with season, changes if there's all of a sudden the recommendations on vitamin D supplementation change. People take more vitamin D and that rises, et cetera, et cetera. So you really cannot use 10 to 15-year-old data in Biobank with Biobank COVID-19 data to get any meaningful outcome. And the other problem was they used too many confounding factors that were directly related to vitamin D in the analysis. So we have another study from the UK looking at patients admitted to the intensive treatment unit. They were younger, 61 versus 76 years, with greater prevalence of hypertension, higher baseline respiratory rate, higher C-reactive protein. While the mean serum 25-hydroxy vitamin D levels were comparable, only 19% of the ITU patients had 25-hydroxy vitamin D levels greater than 50 nanomoles per liter versus 39% of the non-ITU patients. I mentioned earlier that in Israel, they found that the age trumped 25-hydroxy vitamin D. But this study from the UK with patients with an average age of 80 plus 9 years found that the median 25-hydroxy vitamin D for those with COVID-19 was 11 nanograms per milliliter, but the median 25-hydroxy for the controls was 21 nanograms per milliliter. So here, this shows that even at the age of 80, even if they have other chronic diseases, which were not associated with COVID-19, there's still a tremendous difference in the 25-hydroxy vitamin D concentrations. Here's a study from Chicago. They had people with mean age of 47. Whites were 158. The others were primarily African-American, 331 participants. They looked at 25-hydroxy vitamin D measured in the past 12 months. And they found that for comparing to the 187 with greater than 40 nanograms per milliliter, those with less than 20 nanograms per milliliter had an 80% increased risk of being diagnosed with COVID-19. Here's a study in Germany showing that if they had greater than 12 nanograms per milliliter, very few people died. If they had less than 12 nanograms per milliliter, 30% died within 2.5 months. hazard ratio of 15. There have been two very small treatment studies. One in the United States had two Hispanic patients with BMI equals 30, baseline 25 hydroxyvitamin D, about 20 nanograms per milliliter. They were given 50,000 IU per day of vitamin D2 for 5 days. 25 hydroxyvitamin D increased to 40 to 50 nanograms per milliliter. Oxygen use decreased from 15 liters to 0 for 1. The other had no oxygen requirement. IL-6, the primary interleukin associated with inflammation, decreased from 10 and 14 picograms per milliliter to less than 5 picograms per milliliter. Hospital stay was 10 days for the treated patients versus 13 to 14 days for controls, although the controls had diabetes mellitus and hypertension, which may or may not have affected the hospital stay. Here's a more thorough, this is a study, this is a pilot study in a clinical study in Cordoba, Spain. All hospital patients received as best available therapy, the same standard of care, using combination of hydroxychloroquine and azithromycin. And eligible patients were allocated to take oral calcifediol, which is 25 hydroxyvitamin D2. In other words, it's already passed the conversion from vitamin D to 25 hydroxyvitamin D. And so in the first week, they were getting an equivalent of 130,000 IU of vitamin D2. However, the treatment kicked in faster because it didn't have to go through the liver for the processing. And what they found is of the 50 patients treated, only one required admission to the intensive care unit, while of the 26 untreated patients, 13 required admission to the ICU. They show, and this is turns out to be very significant. Of the 13 patients who were not treated, who were not admitted to the ICU, they were discharged. But of the 13 patients admitted to the ICU, 2 died, and the remaining 11 were discharged. So let me, it's near the end here. I want to say that contrary to what some people think regarding evidence as only coming from clinical randomized controlled trials, observational studies really are evidence. They are based on serum 25 hydroxyvitamin D levels. They are generally adjust for possible confounding factors, generally finding little change as a result. Results from observational studies are consistent with known mechanisms and generally for results of vitamin D clinical trials for acute respiratory tract infections and preliminary trials of vitamin D for treatment of COVID-19. So in summary, the severity of COVID-19 is inversely correlated with 25 hydroxyvitamin D up to and above 30 nanograms per milliliter, perhaps even to 50 nanograms per milliliter. To achieve 30 to 50 nanograms per milliliter would take around 2,000 to 4,000 or more IU of vitamin D3 per day. These doses are known to be safe. Risk of death is greatest for 25 hydroxyvitamin D, less than 12 nanograms per milliliter. Those at greatest risk of death are the elderly with low 25 hydroxyvitamin D concentrations. Those with confounding factors and obesity should be concerned, but it's really their 25 hydroxyvitamin D that makes the difference. And many randomized controlled trials regarding vitamin D for prevention of COVID-19 in healthcare workers and treatment of COVID-19 patients are in progress. Thank you.
Hello, my name is Gareth Davies. I'm a physicist and technology entrepreneur specializing in AI. I have a PhD in medical physics from Imperial College, and since March, I've been working as a coronavirus scientist in collaboration with two medical doctors. And in March, we discovered compelling evidence that vitamin D deficiency was the main cause of severe coronavirus disease. So in May, we published a formal proof of this using a causal inference framework, which is a technique developed for AI, and also borrowing a method from physics, a method of proof from physics, which can be used to distinguish causation from correlation using only observable data and not, without the need for an interventional trial. Causal inference is pretty new to medicine, so I'm going to explain here what we did. The first thing that we noticed was that there was a really striking northern hemisphere bias in terms of the deaths. So pretty much below the 30 degrees north latitude line, the number of deaths that were occurring was almost negligible, and yet the world population clearly doesn't match that pattern. And the number of deaths per million on the right was clearly very, very high in the north and almost negligible in the south for all locations. So this is a geobubble plot that shows the severity of the outbreaks using a simple formula that takes deaths and recoveries. And you can see here that above 30 degrees, there were huge, terrible outbreaks, most early on Italy, but Wuhan, the origin of the outbreak, and then in Spain and the rest of Europe. This is up to the 28th of March. This is the same severity index plotted, but this time using a logarithmic scale, because some of the points were just so small, as you saw, they just didn't appear. And again, keeping that going to the 9th of April, so a little bit after March, we saw the blue here is locations that did appear to be having outbreaks, but then went negative, which in the case of this severity index means that the outbreak was completely controlled. And you can see here Brazil just started to have a severe outbreak at the beginning of April, but until then there were no countries in the southern hemisphere. So an obvious question is, well, was this because the northern hemisphere was infected first? But actually, when we looked at the timeline of when people were reporting deaths and recoveries, in fact, most of Asia and the Oceania countries, so Australia and New Zealand, actually got the infection well before Europe. And yet they didn't have outbreaks anywhere near as severe as we did. So that's extremely surprising. Now, the pattern of outbreak happened to match the known seasonal pattern of vitamin D deficiency, because vitamin D is produced in the skin in strong sunlight. And it's known that coronaviruses follow this seasonal trend. So this is how we started to spot the patterns that suggested that vitamin D deficiency might be the reason. We also know that vitamin D is actually a hormone, not a vitamin, and it's involved in immune function. So there's a lot of research from the last 20 years that suggests that actually it's because of vitamin D deficiency causing the immune system to break down and not function properly. And that mapped exactly onto the pattern that we were seeing. So what we did is, in order to prove that the patterns we were seeing were causation and not just correlation, because vitamin D deficiency is correlated with lots of different things, we decided to apply a causal inference framework. Now, this is a technique from AI, but we also we applied it slightly differently using a method from physics, because to use the normal method requires a great deal of very high quality data, which around serum levels, which we didn't have. But what we did have was a great deal of data about lots of other things that we could use to prove. So we created what are called directed acyclic graphs, and these are fundamental to causal inference, and they're models of the cause and effect chain through to any particular outcome. In this case, it's COVID-19 and death. So we categorized all of the root causes that impact vitamin D serum levels, so that anything that increases vitamin D, anything that decreases vitamin D. And then we also looked at categorizing illnesses into 3 categories. So because we don't know if some illnesses cause vitamin D deficiency, whether some illnesses are caused by vitamin D deficiency, and presumably some are not impacted at all. So by creating this model, this gives us a clear way to look at the cause and effect chain. And we created 2 models. They're essentially the same model, but with certain lines cut. So on the left, we've got the causal model, and on the right, we have the acausal or bystander model. And in that, we've cut the lines that would link all of the root causes and vitamin D having an impact on COVID-19. So you can see there are no lines going from those. And what we can do now is borrow a method from physics, which is called the hypothetico-deductive method, and we can make predictions using these models about what we would expect to see in the observable data that we're looking at. And we made 19 predictions from these models. For example, looking at the Northern Hemisphere, we would predict that fatality rates would be generally high because it was in winter and people's vitamin D levels were low. But the exceptions would be places where people were known to, for example, eat a very high fish diet, because it's pretty much the only way you can get vitamin D from the diet is through either eating oily fish all day or taking supplements. We would expect certain populations to be severely affected, and those would be people, the so-called BAME community with naturally dark skin, because melanin blocks ultraviolet light, which converts cholesterol into the first form of vitamin D. And if you've got naturally dark skin, that won't happen. So people with dark skin living in northern climes in the winter are much more likely to be vitamin D deficient, and therefore much more at risk. If this was causal, they would be much more likely to die. So we predicted that BAME communities would have higher fatality rates. And we made a number of predictions like that. Of the 19 predictions that we made, 16 were testable and 3 were not, because we didn't have the data to do that. And so we built a table and looked at the data and made comparisons about whether those predictions matched observable data for the causal model or the bystander model. And because there are so many predictions that we were able to make, that gives what's called triangulation confidence, because if one prediction didn't match, that wouldn't mean much. But by the time you get to 16 predictions, all coming from different root variables, the probability of the model being wrong and the predictions just being random diminishes. The more predictions you can make, the more confidence you can have. And also in any model, whether it's a trial or an observational method like this, the number of data points that you consider is also a strong indicator of confidence. And we analysed 1.6 million reported data points from 240 reporting locations. So this method is capable of producing a very, very accurate and reliable method of result in deciding whether or not vitamin D deficiency was causing the results that we were observing in the world. And in fact, the results were really black and white and quite striking. The causal model, all 16 predictions matched what we saw in the 1.6 million data points, and all 16 of the bystander model, or the acausal model, contradicted what we were seeing, some very strongly and some less obviously, but they still contradicted. So that's very, very strong evidence that vitamin D deficiency was at cause. We also looked at historical evidence. So if vitamin D supplementation is effective at defending against flu viruses, coronaviruses, respiratory viruses in general, then we should know from vitamin D fortification whether that works. And it turns out that between 1930 and 1950, so that's this period marked in yellow here, there was a period where vitamin D was added to food routinely around the world. And in fact, you can see here that there were no new strains of flu during a period from 1920 to 1957 until that vitamin D fortification was banned. And it was banned for reasons that turned out not to be true. So there were scares that people were overdosing on vitamin D, but it turned out to be something else. So that's really remarkable historical evidence that vitamin D fortification in the general population can actually suppress these flu viruses and presumably coronaviruses, as we've proven, to the point where there aren't enough viral particles for mutations to happen in great numbers. And you can see after 1957, when vitamin D deficiency became a problem again, and which is documented, we started to see lots and lots of mutations, because in the world population, there were lots and lots of people getting flu. Finally, I won't go into this into a great detail because it's rather complicated and not the point of our proof, but there's a huge body of research showing how vitamin D biologically interacts with the immune system. We used to think vitamin D just stopped rickets. In other words, it helps laying calcium down onto your bones. But in the last 20 years, we've discovered it's actually a fundamental hormone that impacts the immune system, both the innate immune system, which is the first responder when you first get an infection, the adaptive immune system, which is where you develop antibodies to a particular pathogen, and we know specifically the mechanisms by which vitamin D interacts with many systems and other hormones like estrogen, and specifically with respect to ACE2, the cell receptor that the virus uses to gain entry into our cells. So that really constitutes altogether these mechanisms, the causal inference proof, predictions, the historical evidence, taken together, form rock solid concrete proof that vitamin D deficiency is causing worse outcomes. We know exactly why it is, and we've seen in the data that it's causing exactly the outcomes in subpopulations that we would expect to see if that was the case. Thank you for your attention.
My name is David Grimes, and I'm a retired physician. I'm wanting to talk about COVID-19 and vitamin D deficiency, touching upon Bradford Hill's criteria and Pascal's wager. These are people of great intellect in the past. But before going on to Bradford Hill and Pascal, I'll just talk for a moment about Matt Hancock, who is the Health Secretary of the UK government. And in Parliament 2 days ago, on September the 22nd, he said, vitamin D does not appear to have any impact on reducing the incidence of COVID-19. He went on, and this is the press release, he went on to say, vitamin D is one of the many things that we looked at to see whether it reduces the incidence or the impact of coronavirus, and I had seen reports that it does. We therefore put it into a trial, and unfortunately, the results don't appear to have any impact. So that is the latest clinical advice, which is, of course, always under review. Now, the comments of under review came from the National Institute for Health and Care Excellence, NICE. NICE reported on the 29th of June a completely rubbish report, and the common statement was 3 months later, on the 22nd of June, on the 22nd of September, I'm sorry. So the NICE report said there is no evidence to support taking vitamin D supplements to specifically prevent or treat COVID-19. Now, that was 3 months ago. Has the world stood still for 3 months? Or is it that political thinking has stood still? Have the government advisors been asleep at the wheel? And here they are. See no evidence, speak no evidence, hear no evidence, pretend there is no evidence. And this is a report from the Times this morning concerning Sir Patrick Vallance, the Chief Scientific Officer to the UK government. I'll make no more comment about that. However, medical science has not been asleep at the wheel. And during the past 3 months, or during the past 6 weeks, we've seen studies from Newcastle upon Tyne, Heidelberg, Chicago, Israel, Iran, Paris, and Boston. They have all demonstrated an impact of vitamin D on COVID-19. They are, yes, observational studies. And people say observation does not constitute proof. Well, do people really believe that cigarette smoking causes lung cancer? That was based on observation. So is it discredited from the moment it was published? I suspect not. I ask people, what do you mean by proof? And the usual answer is, well, you know, and something incoherent. Very, very few understand the meaning of the word proof. What it is the fulfillment of predetermined criteria. Proof is never absolute. Things change. And as Maynard Keynes, Sir John Maynard Keynes, the great economist, said, when the information changes, I change my mind. What do you do, sir? Well, we've all got to be able to change our minds, including our politicians. So we now come to Sir Austin Bradford Hill. And he was challenged with Sir Richard Doll from Oxford University to answer the question, does cigarette smoking cause lung cancer? Now, this is a man of immense intellect, and he realized that it wasn't easy to define proof. So what he did, he created a number of criteria, and he decided that if these criteria were fulfilled, that would be proof, which would be pragmatic proof based on the best evidence available at the time. So I'd like to go through these criteria in respect to vitamin D and COVID-19. First, strength of association. Well, in Bari, in Italy, they demonstrated a 10-fold increase in deaths from COVID-19 in those with severe vitamin D deficiency. I call that very strong evidence. Other people might argue, but I call it very strong. Consistency of association. Yes, vitamin D deficiency and COVID-19 go together very well and very strongly. We've seen this in Newcastle upon Tyne, Heidelberg, Chicago, Israel, Iran, Bari, and Boston in just recent weeks. But we need temporality. Vitamin D might be associated with COVID-19 infection or death, but which way round is the causation? We generally think that vitamin D deficiency predisposes to COVID-19, but there is the concept of reverse causation, the argument of reverse causation, that COVID-19 deficiency gives rise to vitamin D deficiency, and there's a good grounding for that. Vitamin D is consumed during the infection process. 125, the active ingredient, when it has done its job, it is inactivated by conversion to 2425. So vitamin D is consumed. So we could argue the vitamin D deficiency results from COVID-19 infection. What it means really is that when we're facing a serious infection, we've got to have a good reservoir of vitamin D so that we don't run out of it. The temporality, the time sequence is demonstrated. The vitamin D deficiency does indeed give rise or predisposes to COVID-19 infection. And this eliminates the reverse causation argument. Temporality, the time sequence has been demonstrated in Heidelberg, Chicago, Boston, Israel, Iran, and Bari. Temporality means that low levels of vitamin D predated the COVID-19 infection. It was the low level of vitamin D that came first. Let's move on now to the next criterion, biological gradient. And this has been supplied to us in the past couple of weeks by Michael Holick and his team in Boston. Here it is. Nothing could show a better biological gradient than this. This is absolutely clear. We can see that as the vitamin D level in the blood increases, the COVID positive rate goes down. This was a sample size of nearly 200,000 people who'd had their vitamin D level checked in previous months. And we can see that those with the higher levels had reduced risk of a positive rate. This is a clear biological gradient. This is what Sir Austin Bradford Hill was looking for, and this is the sort of thing that he found in his cigarette smoking study. Next thing is plausibility. Does it make sense in the scientific world? Well, it does. We know that vitamin D optimizes immunity. We know that vitamin D produced in the sun or taken by mouth is activated to 25-hydroxy-D in the liver, and in the immune cells, it is activated totally to 125 OHD. This is the active ingredient which combines and activates vitamin D receptor, and then the process is to gene modulation. This is well known, it's been established during the past 40 years. Coherence. This is the next criterion. Does vitamin D story make a good story? Well, we've seen observations in biomedical science which do make a good story. Let me add to this ethnicity and seasonality. 25 out of 26 working doctors who died from COVID-19 in the UK were of African or Asian, Black African or Asian ethnicity. They did not experience socio-economic disadvantage, even though they were doctors in the UK. They were heterogeneous in their genetic and ethnic backgrounds. But the one thing they had in common was melanin-rich skin. Let's just look at their countries of origin, of ethnic origin. We can see deaths per million from COVID-19 in the UK is 615. It's a 10th of that in India, a 20th in Bangladesh, Indonesia, and Pakistan. Egypt in North Africa is similar to the Asian nations. Once we look at equatorial Africa, we see a very different level of death from COVID-19, very low levels. I feel rather sorry for a young doctor who comes from Uganda to work in England and suddenly finds out that his increase of dying from COVID-19 increases by a factor of 600. Could it be that in the UK, we have appalling socioeconomic deprivation? Or could it be something to do with melanin, nature's very powerful sunblock, which is a great advantage living on the equator in equatorial Africa. But it's a great disadvantage living 50 degrees north of the equator in the UK, where it is well known people from the African countries and from Asia do experience frequent severe vitamin D deficiency. We've seen a few obituaries in the British Medical Journal of doctors who've died from COVID-19, 20 of them. And on the bar chart, we can see each individual, the height of the bar indicating the age at death. When we analyse, we can see that the white British have an age range of 84 to 107, with a mean of 88. The BAME, the Black African and Asian doctors, have an age range between 48 and 79, with a mean of 69. This is an astounding difference. And I can see only one explanation for it, and that is melanin-rich skin. Let's look at seasonality. We can see here in the UK, COVID-19 new cases each day since the 22nd of March. We can see lockdown introduced on the 23rd of March. I don't see any major evidence of it being of any benefit. But what I do see is a decline of cases throughout the summer when vitamin D was produced in our skin. And as this vitamin D production has ceased at the present time, towards the end of September, the number of cases is increasing. The same with deaths. Again, we see lockdown. We see no major benefit from lockdown, but we see a big change taking place during the time of vitamin D production during our short summer. And we can also see a minimal increase in deaths now at the end of September. There were 37 deaths yesterday, 37 the day before, but at the beginning of this month, there were just about 3 deaths per day. So I would add ethnicity and seasonality to make a coherent picture for vitamin D being of great benefit in the fight against vitamin D and fight against COVID-19 infection. Experimentation was required by Sir Austin Bradford Hill. We've heard this from from Cordoba in Spain, a randomized controlled trial using calcidiol. The experiment showed 26 controls, 13 of whom required intensive care, support, and there were 2 deaths. Of the 50 patients who required vitamin D, 1 required intensive care and there were no deaths. All these patients had proven COVID-19 pneumonia. I read a little while ago in the commentary on vitamin D, says, well, it might do some good, but it won't be a magic bullet. A reduction of ICU admissions from 50% to 2% is, to my mind, as close to a magic bullet as you could wish to be. Some people will demand further randomized controlled trials, but there are ethical considerations. How many patients must be sacrificed to satisfy the skeptics? Would you sign a form of informed consent to be a controlled patient? I suspect not. I most certainly wouldn't. Let's move on to analogy. I could have used the vitamin C story of many years ago, but I'm going to use Pascal's wager. Now, Pascal's wager is this. He said, is it advantageous to believe in God? And I would say today, is it advantageous to promote vitamin D? Pascal's wager is the basis of a 2x2 contingency table. And the effects are in A, B, C, and D. So let's take Pascal's story, his problem. Either God exists or God does not exist. These are absolutes. And also absolute is either you believe in God or you don't believe in God, you reject God. Now, if you believe in God and God exists, you're looking forward to eternal happiness. If it doesn't exist, you've wasted time in devotions and you could have had a lie-in on a Sunday morning. If you reject God and it turns out that God does exist, you're heading for eternal damnation. And if it doesn't exist, well, you've lost nothing. So Pascal decided that it's as well to believe in God. You have the option of eternal happiness. You're not going to have eternal damnation. You might have wasted a little bit of time on a Sunday morning. So vitamin D is either effective or it is not effective. We either promote it or we reject it. If we promote vitamin D, and vitamin D is effective, then many deaths are prevented. If we promote vitamin D and it's not effective, then we waste our efforts. But that's, to my mind, not a big deal. On the other hand, if we reject vitamin D and vitamin D is effective, then there are going to be many unnecessary deaths. If we reject vitamin D and vitamin D is not effective, there's no loss. So Pascal would say, and I would certainly say, it's sensible to promote vitamin D because in all probability, vitamin D is effective and we're going to prevent many deaths. If with our knowledge of the effectiveness of vitamin D, if we reject vitamin D, as is being done by our government, then there are going to be many unnecessary deaths. They will have blood on their hands. The pragmatic approach is to accept Pascal's wager. Is there a good reason to reject Pascal's wager? No, at least there's no good medical reason. So we've now been through Bradford Hill's criteria. We've ticked all the boxes and they're all successful. All the predetermined criteria set out by Sir Austin Bradford Hill in his immense wisdom have been met. Quod erat demonstrandum, QED, as I learned in geometry at school. And that equals proof. The weight of evidence for vitamin D is overwhelming. And my conclusion is this. During a pandemic, not just this one, but during a pandemic, all people should take a vitamin D supplement. Thank you.
Thank you all for those great presentations. Michael Holick has had to leave. I'm Rufus Greenbaum. I'm a citizen scientist. I'm interested in preventive health. And as a result of some of my work, my inner age is my real age minus 18. And as a scientist, I understand the difference between hypothesis and RCT evidence. I've been corresponding with the UK government about vitamin D since 2009. If you want to see my original letter, follow that link, ISGD RG SACN 2009. I had the great honor and privilege of organizing 4 conferences about vitamin D in 2010 and 2011. And again, you can see those if you look at this link. I currently publish the blog, vitaminduk.com, and I have been commercially involved since 2015. So you have to take that into account in what I'm saying. Now, here is the annual blood level of vitamin D in a UK population over a 2 or 3 year period. And you can see, and this is all white-skinned people. These were people born in 1958, and the test was done in 2002, 3, and 4. At the end of the winter, their natural blood level was 35 nanomoles, and it rises to 75 nanomoles in September. It's September the 24th now. This week we've passed the autumn solstice, and the blood levels will start falling. Now, what do you need to do with vitamin D? It depends on your target. If your target is 25 nanomoles, which is the current UK definition of deficient, well, there's no problem. No preventive action required. If, on the other hand, it's 50 nanomoles, there's a minor deficiency for a few months. And again, there's no major preventive action required. But what if you set your target at 75 nanomoles? Well, now everybody in the UK is deficient all year round. Now what do we do? And if you follow the experts' guidance that says we ought to have 100 to 150 nanomoles, everyone is very deficient all year round. Now, what action is required? And what that means is you have to go from our UK definition of 25 nanomoles up to 100 to 150. You actually have to increase the blood level by 4 to 6 times. This is the A plot from Scotland. Look how low they get. In February, they're down at 10 nanomoles, and they don't get much above 45 nanomoles. They've got a problem in Scotland up at 56 to 57 degrees north. 2 key facts. If you want to understand the importance of vitamin D, you need to accept these 2 key statements as facts. If your blood level is less than 100 nanomoles, then you are liable to suffer from some of 88 different health conditions. And vitamin D is a potent steroid pro-hormone made in your body from sunlight or supplements, and very little can be obtained from food. It is not a nutrient. SACN, go away. It's nothing to do with you. Many doctors have been wrongly taught that only a very low level of vitamin D is required, and it's only to avoid problems with bones and muscles. If you persist with this belief, you'll probably reject all the assertions of our speakers and the evidence that higher levels are needed for better health. So read more about it. Here are some links. Follow my blog and Grassroots Health and Vitamin D Wiki. Health outcomes, very good evidence that people with dark skin have lower blood levels of vitamin D than people with light skin. And then when their levels are equalized, then their health outcomes become similar. And this explains why people with darker skin have worse outcomes. Follow that link to look further. If you live further away from the equator than 30 degrees north or south, then you cannot make enough vitamin D from the sun all year round. And in your winter, you will need to find another light source of UVB or take vitamin D supplements. Again, have a look at the shadow rule. There is a delightful talk on TED by Professor Nina Jablonski about the effect of health and skin color and migration. A beautiful talk. And as Michael said, many people who live an outdoor life near the equator, like the Maasai warriors or Hawaii lifeguards, have natural blood levels of 100 to 150 nanomoles. There's an American doctor who walks on a Florida beach every day without a shirt, and he has a vitamin D level of 117. My test results, I take 5,000 IU of vitamin D each day. My last test was 143 nanomoles. But look down the bottom of this slide. The test lab said greater than 50 was adequate. So my doctor's going to look at this and say, oh, you're okay, you're well over the amount. The test labs, DEQUIS in the UK, have to adjust the test result adequate level to be greater than 75 and preferably above 100. How much do I need? How much vitamin D do I need to raise my levels to the lower limit of 100 nanomoles? In winter, I need 4,000 IU a day. In summer, maybe only 2,000 a day. It may be that people are more compliant with a weekly supplement. That's good enough. Michael talked about weekly or 2 weekly. Obese people should increase the dose, maybe double required. Vitamin D is fat soluble. Larger people have less. Those people who cover their bodies should take the full winter dose all year long. Muslim women, religious people who cover their bodies. If you don't take a loading dose, it may take 90 to 120 days to stabilize. The dose response varies for about 10% of the population. Have a look at Grassroots Health to see a study of people taking large doses. And it's required for life. Many doctors think it's like iron, where you only need a one-off top-up. No, you need it for life. And maybe whole families should be tested or supplemented. Well, what are the next steps? Well, let's monitor and supplement vitamin D levels to greater than 100. The benefit to cost is massive for people at risk. It's an easy, hard challenge. Every step is easy, but making it happen everywhere is hard. Who needs to take action in the UK? Our experts need to understand this properly. NICE, SACN, NervTag, SAGE, and Public Health England. Our politicians need to understand it, and our blood test laboratories need to understand it. Who can take local action? Every doctor and nurse can take action today. Pharmacists can take action today. Public health directors need to understand this and take action. Unfortunately, not all public health directors are medically qualified, but they ought to ask some of the experts for guidance. Health visitors and midwives can make a massive difference, and so can care home staff. And think about what would be the benefit for health insurance companies. The major ones in the UK are Bupa, PPP, and WPA. They would benefit from wide supplementation. Their clients would live longer and pay them premiums for a longer time. So for more information, look at the scientific information on the tolerable upper intake from the European Food Safety Agency. Follow that link. Look at the experts' call to D-action on Grassroots Health. And for proof that vitamin D works, have a look at Vitamin D Wiki with the section Proof that Vitamin D Works. What are the next steps? Who needs to take action? Everyone. What do you need to do? Boost your vitamin D to 100 to 150 nanomoles. Why? Because you'll live longer in better health. Where do you need to do it? Everywhere. And when do you need to do it? You need to do it now. You want to learn more? Look at my blog, Vitamin D UK. Look at Vitamin D Wiki. Look at Grassroots Health. And VitaminDassociation.org events has videos from my conferences from 2011. I'm very proud of those conferences. They were videoed, they're up on YouTube, and they are a great learning resource. Thank you so much.